infections just lay dormant for many years before complications set in, and hence the reason they're often referred to as the silent killers and not picked up until much later in the disease process. Left untreated, roughly 20% of adults will develop liver fibrosis and eventually cirrhosis, and then about a quarter of those may go on to then develop end-stage liver disease and liver cancer. And this natural history is highly variable, with many never developing any complications and others having a much more accelerated course, depending on whether they have other viral co-infections and other risk factors for accelerated disease. So viral hepatitis causes about 3 million deaths annually. As you can see from this figure, it's a figure I like to show and update regularly, these deaths now exceed deaths from HIV, TB, and malaria combined, while these other infectious diseases are declining, primarily due to large-scale funding initiatives. Global hepatitis deaths, on the other hand, are continuing to increase and will continue to do so at rates in the blues. You can see this sort of stark increase in rates over the next 10 years if don't make significant global efforts to combat these two viruses. And these are just some of the WHO illustratives that really just, I think, highlight some of the problem of morbidity and mortality from, specifically mortality from hepatitis. And almost 3,000 people die from hepatitis B and C every day, which equates equivalent to someone dying every 30 seconds. One of the most feared complications of viral hepatitis is liver cancer. And something that is rising in incidence locally, globally, and of great concern. And viral hepatitis accounts for about 60% of those of the liver cancer cases each year, and about 80% of those liver cancer cases are residing, or people with liver cancer are residing in very high prevalence hepatitis B regions, as would be expected. So Sub-Saharan Africa, Southeast Asia. And we just completed 2 studies of liver cancer in Nigeria, where we enrolled about 100 persons in each of the cohorts in less than 3 months with liver cancer. So I think it gives you a sense, without even looking at numbers, as to how particularly problematic it is, particularly in West Africa. So unfortunately, liver cancer is very aggressive, associated with very poor prognosis, even in high-income settings, with a median survival anything around 6 to 20 months, 70 days in our cohorts in Nigeria, which is very poor survival rates. And it's projected that the number of people diagnosed with liver cancer and dying with liver cancer could increase more than half between 2020 and 2040 if current rates don't change. And certainly we have to really intervene with viral hepatitis, given that it's the major cause of liver cancer worldwide. So what about the global public health response to viral hepatitis? So as this slide will show you, really until 2010, hepatitis B and C were largely ignored by the international health community. And this is despite us really knowing about these viruses for some time, several decades. We had even effective therapies for, by this time, for hepatitis B, and a very effective vaccine. And I think much of this inattention could really be blamed on the silent and chronic nature of hepatitis B and C, which compared to diseases like HIV and TB and malaria at the time, didn't look like they were progressing as quickly, don't possess the same frequency of visible trauma, and seem to be less stigmatizing. And of course, most of the infections were occurring in lower and middle income countries. Whereas we've seen with HIV, if you don't have the tools to diagnose these infections or assess the burden of disease associated with those infections, they're very easy to ignore. So in 2010 was when the first resolution on viral hepatitis was adopted by the WHO, was passed, and then the second one was voted in 2014. That was followed by the very first guideline in 2015 for the treatment of hepatitis B and C. But really, the landmark event that put sorry, just move back a slide here, that put global hepatitis on the world stage was this announcement of the Global Health Sector Strategy on Viral Hepatitis, which was adopted by the World Health Assembly in 2016. And this strategy outlined key activities to achieve viral hepatitis elimination and set clear hepatitis elimination targets to be achieved by 2030, with the interim targets in 2020. And these included a 90% reduction in new chronic infections and a 65% reduction in mortality compared to 2015 by 2030. With the very ambitious overall goal of sort of eliminating viral hepatitis as a viral public health threat by 2030, and with the emphasis on eliminating as a public health threat, not eliminating completely, which a number of people have kind of raised. A number of other service coverage targets, which are shown in the table on the right, were included, such as increasing childhood birth dose vaccination coverage for hepatitis B, which we'll talk about a little bit later, safe injections, other harm reduction services, and then increasing the numbers diagnosed and treated. So in 2021, was when the first report, first global report, progress report, was published, which highlighted achievements and gaps in the implementation of these global health sector strategies and targets for viral hepatitis. And in this report, there was also a progress report update on HIV and sexually transmitted diseases, which also had targets included. And this report made for a very sobering one with regards to viral hepatitis, where it was clear sort of fairly immediately we were nowhere near on target to meet the 2030 elimination goals for most service coverage and impact targets as outlined in the previous slide. And in fact, in 2019, only 2 targets were met, including the GHSS target of reducing the global hepatitis B surface antigen prevalence among children younger than 5 years to less than 1%. So that was down to 0.94% as a result of vaccination. And then increasing an increase in numbers of persons treated for hepatitis C, which was well above the 3 million 2020 goal, and is probably the result of the more access to the curative therapies. Unfortunately, most other global targets were missed, or at least for the 2020 targets were missed, especially including the number of new infections, mortality reductions, access to timely birth dose vaccination, which is only coverage of 42% in 2019, testing coverage, which shown the 2 bullet points below at the bottom of the slide, which were far below the 2020 targets and certainly nowhere near the projected to achieve the 2030 targets for proportion tested. So how close we are to eliminating, or at least how close we are to achieving elimination of both hepatitis C and B by 2030, or eliminating as a public health threat, is really best illustrated in these maps generated by the Centers of Disease Analysis Polaris Observatory, which creates these data, tools, and prediction maps to support informed decision-making at national, regional levels for hepatitis elimination. And as you can see, for hepatitis C, only 11 countries are on track to eliminate hepatitis C by 2030. And for hepatitis B, a lot of red here, no country is expected to be on track to reach the 2030 goals. Although I should mention that several countries are actually on track to meet that target that's already been met, the under 5 prevalence of less than 0.01%, which was the target for 2030. So all this does is highlight the fact that clearly accelerated action is needed to reach these elimination goals. Since it's probably primarily a US audience, so I can't tell who's watching, but I know we have a lot of people from other countries, but probably worth mentioning the US and some progress here. It has been perhaps a little quicker, some turnaround, but some metrics haven't quite been met. Has been a substantial scale up of activities related to viral hepatitis, especially since having direct acting antivirals or curative hepatitis C therapies available. I would say most of the momentum is in Hep C, with more attention to Hep B recently. And over the past decade, we've had about 3 national viral hepatitis plans have been published, with evolving priorities culminating in this national strategic plan shown here. And just to give you kind of a sense of where we are with some of the annual targets, so for hepatitis B, although trends in reduced new infections overall and among drug users are on target, it's concerning we're not quite meeting annual targets for reductions in hepatitis deaths overall, particularly in minority groups, which have the highest hepatitis B prevalence. And for hepatitis C, annual targets have not been met for reducing the estimated number of new infections, which could be just from reflective of increased testing. And it is encouraging somewhat to see mortality declines with hepatitis C, but not in all risk groups. Again, those marginalized communities or minority communities most affected. So why has progress been so slow globally? So this slide just outlines some of the most important barriers to elimination of hepatitis B and C. We really say some of these barriers are very particular in low middle income countries that don't necessarily have resources, where elimination is not a priority, funding is not there. The first, sort of just going from the top, is no particular focus on priority, but a lack of surveillance systems is one problem where, if you don't have them to monitor and measure the incidence and burden of disease, it leads to big information gaps, knock-on effects on policy, and sort of a lack of attention to and awareness of viral hepatitis. There's also a significant under-utilization of measures to prevent new infections, primarily prevention of mother-to-child transmission strategies, hepatitis B vaccination, and then early diagnosis and treatment, all key to prevention, and all primarily driven by a lack of accesses to resources, financing and logistical challenges, and a lack of effective policy at both national and international levels. There's problems with limited and inequitable access to treatment and monitoring, again, driven by high costs, a lack of resources, access to specialized care, and then stigma and inequality continue to disproportionately affect those with hepatitis B and hepatitis C, and significantly under-recognized until you start working with these populations and researching them, particularly in communities that are economically disadvantaged, displaced people and migrants. And then there are several missed opportunities to integrate and link care, leverage existing health services, which we know work, which on a programmatic level are really crucial to elimination efforts. And then, of course, the major barrier being poor political commitment and insufficient investment, which plague really viral hepatitis field and really central to all these other issues mentioned. But it's not all that bad. And despite not meeting the targets, there has been, at least as I sort of alluded to in the last couple of few slides, that there has been much more attention to viral hepatitis and very many exciting advances in the field with both hepatitis B and C that give me great hope for in the future for their elimination, maybe not by 2030. And it is encouraging to note that the report the last progress report did mention that 70% of countries and regions worldwide have actually formulated a national plan to achieve those WHO goals of elimination, but fewer of them, although fewer of them, 50%, have the right funding for that, at least to cover the entire plans. So in the next few slides, I just wanted to go over some of the advances that have been made, and in terms of sort of evidence gathering, prevention, diagnosis, and treatment with regards to viral hepatitis B and C, and then talk about some of the research that has been done by myself and others, and examples of very successful program interventions that have been that have been done to try and address some of the major barriers to elimination and to really progress the field. And then as I said before, I'll summarize some of the priorities, I think, for the next decade. So in low middle income countries, as with many infections, the development of elimination strategies are often hindered by a lack of good quality data. And in countries where national surveillance systems are lacking, and we have to kind of rely on some of the local and national epidemiologic studies to get a sense of the real true burden of viral hepatitis infection and some of the complications. And this type of data, while a little bit siloed, is really helpful to inform policy strategies and demonstrate that various prevention and treatment strategies have worked and how they reduce the burden of liver disease. So in Sub-Saharan Africa, where I mentioned a lot of the viral hepatitis, we're just only beginning to start understanding more about hepatitis B and C in these particular settings. And the paucity of data up until this time has really think primarily the result of a lack of access to and the high costs of sort of serologic and virologic tests necessary to characterize these infections, and a lack of tools for liver disease screening that we have to assess the burden of complications. And over the past couple of decades, I've had actually the privilege of working in Tanzania and Nigeria on a number of epidemiologic studies characterizing viral hepatitis, most of it hepatitis B, and assessing some of the liver disease burden with these infections. And this slide just sort of summarizes a couple of projects we had set up back in the 2000s when we actually were working on HIV programs. We established some research cohorts of hepatitis B infected populations with and without HIV to examine the burden of liver disease in these individuals and liver disease progression while on treatment among populations with these infections using non-invasive blood testing and FibroScan. And we were actually the first sort of group of people to look at liver disease in this setting. As you can imagine, it hadn't really been studied before, because at that time, which was about 10 or so years ago, liver biopsy was actually still sort of considered the gold standard for assessing liver disease, and that was just not feasible in these settings. This slide just kind of summarizes some of the key findings from the work we did. I think just to highlight, so interesting, one of the first things we noticed was actually there's a relatively low burden of liver fibrosis in hepatitis B populations, even with HIV, which is known to accelerate liver disease. It was not unexpected to then see when we did some more analysis that most of this fibrosis that we saw a little bit higher among persons with HIV, the scores were a little higher, even though sort of low overall. It was not unexpected to see this was a lot related to the HIV and hepatitis B disease activity as measured by their viral loads. Interestingly, sort of in follow-up studies, and we've been able to follow one of these cohorts out to 6 years, we found that those with HIV and hepatitis B co-infection continue to have the higher liver fibrosis scores, and in about 14% of the population, they actually increased, despite having effective therapy, antiviral therapy for both their hepatitis B and HIV, which suggests that maybe the treatment, we have to kind of raise some questions at least about the effectiveness of the treatment and whether these patients need more regular monitoring. Among our co-infected, we did see a very high early mortality, which again, probably wasn't too surprising, and actually mostly related to the HIV and immunologic suppression as opposed to their hepatitis B disease activity. Far less data has been published characterizing hepatitis B mono-affected populations, and probably because these populations are sort of slightly less accessible because they're not really enrolled in treatment and care. And in our Tanzania cohort, we were actually able to enroll some of these individuals, and found overall they had low rates of mortality, low rates of fibrosis, low activity, disease activity. But interestingly, all the 5 deaths that did occur by the end of this study were all liver related and in people with relatively inactive infection. Hep C, additionally, has not really been well characterized, particularly in Sub-Saharan Africa. Most studies have actually just reported prevalence of antibodies, which does not distinguish between active and resolved infection. In 2 studies we conducted, one of the first studies actually in this region to conduct and look at actually active hepatitis C infection with hepatitis C viral load testing, which is almost impossible to come across or to do, given the high costs associated with that test. We were able to determine that about 6% of persons with HIV and 22% of persons with liver cancer were infected with active hepatitis C. And this really suggests, this really sort of brought to the attention that it's not just hepatitis B that plays a major role in developing liver cancer in this region, hepatitis C does too. And so we really need to kind of ramp up our efforts in getting people treated or even prevent it from occurring in the first place. So this is just work from our cohorts, and we've had a lot of other work, a lot of other studies have been done in that time by other groups. Many questions have been raised. As always, research leads to more questions. And we will be attempting to answer some of these sort of epidemiologic questions which are relevant to the elimination agenda with our new network, multisite longitudinal study of hepatitis B and HIV Hep B we've created within a new network with my partners from Mali, Tanzania and Nigeria. And we're really excited that the Institute for Global Health is funding this effort, and we're about to start enrolling next month. So very important and timely to do this work. So moving on to screening and diagnosis. So, this is really pivotal to elimination. So how do we find these missing millions? So as I mentioned earlier, testing and diagnosis of hepatitis B and C are really a crucial part of the effective response to the hepatitis B epidemics and hepatitis B and C epidemics, as it provides the gateway for access to both prevention and treatment services, as you can see in the right side, this figure on the right, and the continuum of care. And despite the high global burden of disease due to chronic viral hepatitis, as well as advances and opportunities for treatment, most people remain still undiagnosed and unaware of their infection, as highlighted in the progress report I showed you. And in data from 2019, and as you can see across in this left figure here, just across the different regions, only about 10.5% of persons living with hepatitis B knew their status, and about 21% living with hepatitis C. So very, very low diagnosis rates. And these people are, obviously are frequently presenting with advanced disease, not getting diagnosed until they have advanced disease, and it's really just a burden to the healthcare systems, and of course a high risk as well of transmitting the infection. So early testing, we know, allows early identification of people with hepatitis B and C, reduces their long-term liver complications, reduces transmission. And we shouldn't also forget that early testing, also not just early testing, but just testing as general, provides the opportunity and to link uninfected people to interventions to reduce the risk of hepatitis acquisition. Just on the subject of testing, to just illustrate some of the challenges we've had in Nigeria, I just wanted to kind of share this data. So this was a study that colleagues and I in Nigeria, Dr. Abaji and the team looked at, where they looked at rates of hepatitis B surface antigen testing in HIV clinics between 2004, when those clinics began, and to 2020. And as you can see in this figure on the right, we observed a significant decline in surface antigen testing among persons with HIV as policies changed with respect to testing and awareness, and primarily in this region, it was more of a lack of funding. It's worth noting that there is no policy with regards to hepatitis C testing in HIV populations, despite the well-known documented high prevalence of hep C in this population. So one of the biggest barriers to testing and hepatitis B and C in resource-limited settings is, in addition to just case finding and making testing accessible, are the tests themselves. And so just one look at these two testing schemas for hepatitis B and C just shows you how complicated it is. And essentially for both infections, they require a two-step process to diagnosis, where this confirmatory virologic testing following an initial antigen or antibody test, depending on the infection, is required to diagnose either an active infection in case of hepatitis C, or determine who meets eligibility criteria for treatment initiation in the case of hepatitis B. And this need for this sort of confirmatory virologic tests are really a big bottleneck to testing and access of testing, because they require, patients have to come back for testing often at a later date, which leads to high rates of loss to follow-up, particularly if the clinic is far away. They don't see a need for further testing, particularly if something can be done down the line, especially if treatment can't be offered. And virologic tests themselves are hugely costly, have long turnaround times, and require a centralized lab and skilled workforce. And I've just seen that being a huge barrier to testing in Nigeria and Tanzania. And they really do limit the timely diagnosis of hep C and B in these high prevalence settings. Fortunately, there has been a lot of work on developing point-of-care diagnostics, which I have just put in summarized here in this table on the left. This field very much driven by UNITAID, WHO, NGOs, provide a lot of funding in this area. Several have been approved, as shown in this table here. So the first is sort of lateral flow immunoassays for detection of surface for antigens and antibodies for viral hepatitis. And then the next sort of group are devices that have been developed for confirmatory viral load testing or nucleic acid testing, including the Gene Expert, which some of you may be aware of and familiar with for TB, which is used in the quantitative and qualitative measurement of hep C and hep B viral loads. And a third category here is a DBS, a dried blood spot, which is more of a point of care technique for specimen collection. And the point of care viral loads, particularly for hepatitis C, we've got a lot of data now showing they've been very effective in reducing the time between initial treatment, initial testing and treatment initiation. So it'd be remiss of me not to mention at this point in time, at least currently, we have work planned in our institution by Dr. Sally McFall on a similar point of care device for hepatitis C viral load testing using the DASH analyzer, which was developed at Northwestern and FDA approved for COVID testing in 2022. And this particular test or adaptation of this test could really offer significant advantages over even the current point of care devices in terms of workflow and testing capacity and turnaround time. So we're really excited to get that work done with funding. The use of dried blood spots for specimen collection can also considerably simplify screening and diagnosis of hepatitis B and C in lower middle income countries and can be used with existing technologies. And in a study we're conducting in Nigeria with Abbott Labs and colleagues at the University of Jos, with funding from C-THAN, we're comparing the sensitivity and specificity of dried blood spots to venous samples for the detection and quantification of hepatitis B and C viral loads, as well as core antigen for hepatitis C, which can also avoid viral load testing. And these will run on standard Abbott analyzers, but the whole sort of goal of this is to propose, and if it's successful, to propose an alternative strategy that could actually, despite sort of using the standard analyzers and the still sort of centralized testing, could significantly reduce turnaround time in terms of more rapid testing, faster and easier transport of the DBS as opposed to venous blood samples to the central lab, quicker turnarounds, obviating the need for a second visit. And in the case of Hep C, if the core antigen works, that would obviously, we wouldn't need the viral load testing for that. So several other novel approaches have been studied and published to improve hepatitis screening, particularly in hard to reach populations, which is the populations we really need to reach. No amount of good tests and good testing you don't have strategies to reach those populations, it's not going to work. They have things that have been shown to be very successful. I just sort of summarize them here and put some links into some of the data on that. And some of these have been shown to be successful, include leveraging community and peer networks for testing, obviously the point of care testing, digital crowdsourcing interventions, some really fascinating work in that area, financial incentives, and then testing at specific clinics. And we actually have a study ongoing right now, actually led by Ravi Javeri over in Lurie, which will be testing specifically for hepatitis C and B, using dried blood spots at antenatal clinics, so reaching people who are not normally tested in routine care. So closer to home is worth mentioning there have been two sort of pivotal recent guideline changes announced in the US, which with regards to hepatitis T testing, which includes universal hepatitis B testing, which will hopefully considerably reduce stigma and reluctance to test. That has been sort of prominent problems with the risk-based screening. So you can imagine with the sort of risk-based screening, a lot of people just don't get approached or don't think they need testing. And this could really, this universal testing could really avert, and has been sort of proposed or hypothesized that it will avert a significant number of hepatitis B cases and obviously liver complications down the road. The other big guideline change was which was very recent, was the introduction of hepatitis D testing to perinatally exposed infants. And this was really a policy change in response to the growing incidence of hepatitis C and thus potential for perinatal transmission among women of reproductive age over the past decade. So moving on to treatment. So on the hepatitis C front, we've had obviously significant advances. So I think everyone's aware that in 2013, we had these new oral medications called the direct-acting antivirals that target three of the main proteins in hepatitis C replication were developed that were found to be curative in almost everyone. So over 95% of people with just 8 to 12 weeks of therapy. And until this time, shown on the graphic on the right, we didn't really have many therapies available, and they were injection form only, very toxic, and offered very little chance of cure, and often reserved for the most sick, who had the least chance of cure. So the development of these DAAs was really considered a watershed moment in hepatitis C, and we now have 5 different combinations that have been shown to be highly effective in persons with and without cirrhosis, and those including those with HIV, as shown in some of this data here, who in the past responded poorly to older therapies. These are just a couple of the studies we were involved with in our clinic and on a national scale that showed similar cure rates. So that's SVR12, that's what we consider cure in hepatitis C with these new DAAs. And equivalents in populations that were harder to treat. And we've seen similar cure rates in persons underinsured, drug-using populations, everyone we thought may not be successfully treated who were, as long as they have access to therapy. DAAs have shown many studies now to be effective, not just with cure, but they improve patient outcomes. They've been shown to have massive cost savings, reduce mortality, improve survival, and also contribute to declining incidence and data. I'll show you later. So one concern, of course, about these new antivirals in LMICs when they first came out was the need for close monitoring, but we now have really good data from ACTG study called MINMON, which is described in this slide here, that showed that direct-acting antivirals can successfully achieve high cure rates, even when they're administered with very little monitoring. And in this study, patients were administered the whole course of 12-week course of hepatitis C treatment, which, by the way, the study enrolled from multiple places internationally across the continents. With 12 weeks of treatment and very little intervention, actually just a phone call at 4 weeks, and just before the test of cure, and no labs and no treatment visits, no labs or visits in between, they had cure rates very similar to all the trials where we've shown those demonstrated those cure rates of over 95%. So not everyone has access to these effective, direct-acting antivirals. They still remain very inaccessible in many low and middle-income countries for various reasons I won't get into today, but with regards to sort of generic access. But where countries have had access to cheaper generic versions of DAAs and a good rollout policy, some significant progress has been made, and Egypt, I'm sure you're all familiar with, has been one of those success stories. Their public health campaign, which actually started actually before the DAAs became available, they screened almost entirely the whole population, treated more than 4 million people, and had showed a reduction in hepatitis B prevalence from 10% down to 0.38 over a decade. So extraordinary work, and lots of things went into making this work, including robust public health care infrastructures, inclusive care that included all sectors of society, political commitment, you name it. So you can just shows that you can do this with effective leadership and policies. Even with therapies, we have many barriers to accessing actual treatments, even if they are available, especially among vulnerable and hard to reach populations. And then, and this is just a study that was conducted by Dan Im with Shannon Galvin within the Hepatitis C Focus program we had here at Northwestern, which just shows that even a third of patients identified with hepatitis C, to diagnose a hepatitis C in the inpatient setting in Northwestern, only a third of those were successfully linked to care. So just showing many of the challenges that we have just accessing difficult populations, and we really need to do a lot of work in this area. Several countries across the world have instituted models of care with regards to rapid treatment initiation, which is to really target some of these hard to reach populations of hep C therapies. And here I've just highlighted just a few that have used a combination of approaches. So on-site care, drug delivery, mobile testing and treatment, integrated care, use of community health workers, and have had really successful programs that have really increased substantially the proportion of people tested for hepatitis C and then successfully receiving and completing hepatitis C treatment. We have many elimination projects over the US, which I won't go into today in the interest of time, but just to give you a snapshot. So some of the programs which are now being embraced and scaled up nationally by our Biden-Harris administration in their 5-year national hepatitis program plan. What about hepatitis B? So probably less progress has been going on in this area. We only have currently 4 approved antivirals and nothing really new in the last few years. Those currently approved antivirals are listed here in the box below. And while not curative, they are very effective at reducing viral loads, suppressing virus, and preventing long-term disease and associated complications, and shown to improve survival. Unfortunately, despite them actually being relatively cheap and some patents lifted and access to generics, there are only 10% of people worldwide who are eligible for therapy. So 10% of people with hepatitis B who are eligible are accessing these treatments, and it's for a multitude of problems. Really to do with sort of access to specialist care programs that will administer them. Just sort of, just hasn't been the investment in this area for hepatitis B monoinfection, at least in many low and middle income countries. And then treatment is further complicated by the really complex eligibility criteria, as you can see here in this slide. The guidelines or the guidelines for treatment, and these are just like 5 to 4 different guidelines, but they really vary in their how their approach. Many of them rely on viral load measurements, which I mentioned before is not very accessible. It's costly, and then just another hindrance to kind of getting people on treatment. So without going into too much of the biology behind hepatitis B, currently sort of treatment is recommended in the most sort of active stages of disease where there's a lot of active inflammation and fibrosis. And the problem is that many of these people also, even if you did have access to their testing, don't really fit into that zone. And it's just really sort of complex. And I think, many people are getting complications even without active disease. And so I think what we're going to see is a change towards a sort of field, and we're sort of starting to kind of hear some discussion about that to push for earlier treatment and to make these treatments for hepatitis B much more accessible to people earlier in the stage of their infection, and to sort of really kind of make treatment protocols a lot more simpler, and hopefully get sort of even the field with regards to treatment access. Finding a cure, there has been there's been a lot of momentum as well as industry investment in developing new therapeutics for hepatitis B. Our hepatitis B therapies, as I mentioned, are not curative. Most people have to be on them lifelong. And so there has been a lot of movement in this field, an exciting movement that I'm also involved in, sort of riding on the success of hepatitis C. But it's several years in development. And I don't think we can sort of see, we are sort of doing sort of phase 1-2 trials right now, but I think it will be several years before we see sort of the revolution that we had with hepatitis C. The therapies themselves can be sort of broadly classified as direct-acting antivirals that target different stages of the life cycle to reduce replication, and host hepatitis B targeting agents that work to induce adaptive and innate immune responses. With these therapies, the likelihood of complete viral eradication is unlikely, given the complex biology. Rather, probably what we're going to be looking for is a functional cure, or what we're succeeding to achieve is a functional cure with these therapies. And that is defined as a surface antigen loss for at least 24 weeks off treatment, and seems to be the much more realistic and desired outcome of these therapies. And in fact, early trial data for some of the novel agents have shown that functional cure could be significantly higher with these agents, as opposed to the current nucleoside therapies we had that I showed in the slide earlier. And that could, obviously substantially improve long-term outcomes in some of these individuals, as well as allow many patients with hepatitis B monoinfection to stop therapy in the future. So many of these trials are ongoing. Unfortunately, most are actually going on in high-income countries, and just like our experience with medications for hepatitis C and HIV, unlikely to make it into the LMIC kind of stage in any timely manner. even if they're approved here, and they're going to be quite expensive, and we could go in for hours to discuss the downsides of that. But for these reasons alone, it's really crucial to continue ensuring access to available therapies that we have right now for hepatitis B, and simplifying the treatment protocols, and really pushing for participation of countries in some of these clinical trials, which we're hoping to do with our network. Okay, so finally, prevention. So just to kind of wrap up here, so this slide just shows sort of the WHO's essential package for viral hepatitis prevention, measures of which I kind of alluded to earlier, really focus on sort of prevention of perinatal transmission, hepatitis B vaccine, safe injection practices, promotion of safe sexual behaviors, and early testing and treatment as secondary prevention. Without doubt, the hepatitis B vaccine is the most effective way to prevent hepatitis B. It's been around for a long time, highly effective, been shown to be associated with decreased liver cancer rates, offers a great deal of protection. But unfortunately, many programs, especially in LMICs, still lack proper protocols and guidance for routine vaccination, even in adults where there's still some considerable transmission. Vaccination of newborns is critical to global elimination, particularly as it represents the primary route of transmission of hepatitis B in the highest prevalent regions. So in the absence of any PMTCT measures, the risk of transmission from mother to newborn is about 70 to 90% for mums with high hepatitis B viral loads. And as you know, perinatal infection is associated with a great over 90% chance of chronic infection. So vaccines at birth can reduce that risk significantly down to as much as 75%, especially when the first birth dose is administered within 24 hours of birth, as shown in the right here. And programs that have been introduced have shown that have introduced birth dose vaccine have shown significant declines in hepatitis B transmission as a result of infant vaccination, and decreased complications down the line, as in the graphs here. Unfortunately, despite its proven efficacy and success in many countries, the coverage rates for birth dose vaccination in some of the highest prevalence area, and particularly Sub-Saharan, which remain really poor, and less than 10% in some of those countries. And there are many reasons for this, and includes a number of sort of high out-of-facility births where there's little access to the vaccine itself. And then there are other barriers like, lack of cold chain storage requirements, limited number of skilled birth attendants, particularly in rural areas, and just many barriers to sort of enforcing this, or at least having a significant scale up of birth dose administration. Many countries in this sort of poor performance area are actually really scaling up efforts, and Gavi is also behind this initiative. So we really kind of hope to move in this area. In high-income countries, the addition of antiviral prophylaxis for the mum as an add-on strategy for prevention of hepatitis B, mother to child, has also been a proven strategy. The data to support this is a little bit more sparse in low and middle income countries, and it's really a little bit challenging because some of these protocols again require viral load testing to determine which mums are going to benefit best from these antivirals, and that's a considerable challenge that I mentioned earlier. Not to mention the challenge of tenofovir, or the drug, the antiviral that is needed to prevent transmission, not always available, and the high cost of just monitoring. And this has led to several groups to recommend some to help bridge some of these gaps, including offering prophylaxis to everyone, including pregnant women who test positive, and regardless of sort of their risk stratification, which could significantly reduce the inequities and potentially long-term complications and mother-to-child transmission down the right line. Hep C prevention strategies, a number have been shown to be very effective, especially in drug-using populations. In the interest of time, I won't go over over all of these in detail. Suffice to say, just one slide on the hepatitis C treatment as a prevention, which is a very, this is really going to be the treatment is going to be very pivotal in I think, moving the field of elimination with hepatitis C, as we can see already that are seeing significant declines in incidence of hepatitis C in countries where they've had access and what they call broad access, so pretty much everyone who's eligible getting treatment, where they have this DAA access. Has been a significant reduction in hepatitis C incidence, as shown on the slide here. So I think this sort of concept of hepatitis C treatment and prevention is really working, and again is going to be very pivotal for moving forward with elimination efforts. So just to quickly summarize, hopefully what I've sort of been able to convey to you today is that chronic hepatitis B and C are highly prevalent infections worldwide and associated with a large burden of disease that I think is really still very underappreciated. Fortunately, we have growing awareness and attention to this problem of global hepatitis, and the concept of elimination of hepatitis by 2030 with these clear and specific targets is now well recognized, and people are really moving forward in this area. Unfortunately, while elimination may be possible down the line, I think by 2030 it's highly unlikely, but we shouldn't slow down our efforts to try and achieve that target. And we really have to focus on what the major barriers are to elimination, especially in low and middle income countries, and that is discovering these missing millions, so the large proportion of people who go unrecognized and undetected, and of course inequalities to access to screening, effective prevention and treatment, and reaching the at-risk, the highest sort of the hidden populations as much as we can. So what will it take to make elimination feasible? I really just put sort of separated them into kind of hepatitis B and C, but many of these efforts are really across the board for both infections. Really for hepatitis B, we're going to have to significantly ramp up our vaccination efforts, universal hepatitis B vaccine, implementation of vaccine for all newborn babies, really find good strategies around getting around that area because we know it works. Improve access to existing therapies. The new ones aren't coming anytime soon. Broadening and making much more simpler those treatment indications for hepatitis B therapies, I think will be is a very astute way to go. An investment in obviously newer therapies as we move forward. But for hepatitis C, we all have clearly very good test and treat models of care that should be significantly ramped up, and that is part of our national US strategy. We want to, obviously, improving access to DAAs is an imperative, as I've shown you, can work wonders in terms of prevention, and really will be successful, really key to elimination, and of course focusing on harm reduction services, targeting people in the most need, and maybe a case for a hepatitis B vaccine, maybe a discussion for another day. And sort of with both, of course, the key is to make sure that we have equitable and affordable testing and treatment, leverage sort of existing platforms to, just create some unique models of care that really work in the settings according to their priorities, improve surveillance, good designed public health research, and really what's critical is going to be the funding, political awareness, political will, awareness, and advocacy, which without everything else is going to be, if you don't have that, nothing's going to work. So I will stop there and acknowledge my colleagues in the field, as well as funders, and a really big thanks to everyone who's made this work possible and who continues to advocate, the whole hepatitis community, and some great people I work with. So stop there. Thank you.
Well, Claudia, thank you. It was a fantastic and very thorough presentation, very illuminating, really incredible. We have time for a couple quick questions. So they're in the chat box. I'm just going to sort of edit them. Here's one from, what would a 50-year-old Nigerian diagnosed with hepatitis B, currently on TAF, his target is to get cured. What could he do in Nigeria? Can you refer anybody for any kind of cure type therapy for hepatitis B there?
Yeah, so the great thing is that I will say that he's on treatment, and I'm really glad to hear that person is accessing treatment. Right now, I'm not aware of any kind of the newer studies, so the novel agents for the newer sort of therapeutics are ongoing in Nigeria, but certainly I'd be happy to link you up, if we do hear about those opportunities, but also just to chat.
Yeah. Great, thank you. What strategies could be used to increase birth dose vaccine for HBV in low and middle income countries? I'm sure this is talked about a lot.
Yeah, so yeah, it's not something I got into a huge discussion about. Thank you, Marion, and sort of really briefly touched on the surface. But there are a lot of programs that are sort of, I think, first of all, funding, and think that really we've got to get people behind this, find unique ways and novel ways of really accessing those populations, or the pregnant mums that just don't get the chance to be even offered the birth dose vaccination in the first part. And that may be, do we find ways of getting that birth dose vaccine to sort of more of the rural locations where it's not accessible, or it's being able to sort of deliver care for these mothers in a sort of more unique way. So it's funding and finding sort of unique ways to access to really get these vaccines to the populations that need them most, and those who are most remote. So.
What do you think is the reason for the low burden of severe liver disease and HBV mono and co-infected individuals in Tanzania compared to the US?
I think it's,
That's a good question. Yeah.
It's
from Marion Peters.
Great question. And I think we were a little surprised. I think it really reflects, I think, at least in Sub-Saharan Africa, the relatively inactive disease stage of hepatitis B. And so I think, we've seen in our hepatitis B mono-infected patients that, or persons in the studies, even without HIV, that most of them are sort of E antibody with low viral loads. What we sort of consider this inactive stage of disease. And so, maybe they've had that for years, and then they get their HIV, and it really isn't, there's not much in the way of hepatitis B activity, even with HIV. And I think that's probably what's contributing to the sort of low rates of liver damage.
Yeah, it's really amazing. What do we know about Truvada PrEP for HIV prevention and high-risk MSM, and how this reduces and impacts HBV transmission and acquisition?
Yeah.
Do you know anything about that?
Thank you for that question. I didn't actually include anything on that, but again, it's another area where PrEP has been shown, at least some studies from Europe have shown that it will protect against hepatitis B transmission and acquisition. It's, I think we have good data to show that, and of course, some of these trials are from sort of countries where they also have been vaccinated, so it's a little sort of tough to say, but there's no doubt it works. So.
Yeah. We're out of time. I'm sorry, we have one other question, but Lisa Hirschhorn has a question for you. She can ask you later. Anyhow, thank you very much, Claudia, and thank you, the audience, for joining us and for your thoughtful questions. We invite you to join us at our next seminar, taking place via Zoom on Wednesday, February 7th. We're excited to feature Joseph Makima, and he's from the Botswana Harvard AIDS Institute for his presentation, Roadmap to Botswana Ending the HIV Epidemic. This will be held by Zoom, and you can register via the QR code here, our newsletter, and social media pages. Again, thank you for joining us today. A recording of the webinar will be available online and will be shared via our newsletter. And this concludes today's webinar. Thank you so much. And thank you again, Claudia.